Fistulogram, how it's helped in MRI. Actually, MRI fistulogram. Topic highlights is what we going to learn from this topic. General idea about fistula and sinus tract, anal canal anatomy and types of perianal fistula. Discuss the role of MR imaging in evaluation and management of perianal fistulas. List the MR imaging sequences and protocol used in evaluation of perianal fistula and other fistulas. What is fistula? It is an abnormal or surgical made passage between a hollow or tubular organ and the body surface, or between two hollow or tubular organs. That means it has two ends. One is external opening and one is internal opening. And it may be abnormal or may be surgical. You maybe notice in dialysis patient there is arterial fistula, AP fistula was done for their dialysis. So that is surgical fistula, and in other it is abnormal fistula. And often we misconcept that fistula and sinus, but both are not same. The sinus tract is an abnormal channel that originates or ends in one opening. That means it has one opening and one is blind. Here it is from the skin. There is the first image is sinus, only one opening and one is blind. And in second, there is a from the skin to intestine, it is opening, that is this hollow tubular structure. This is called fistula. Anatomy of the anal canal. The anal canal is cylindrical structure surrounded by two muscular layers, the internal and external sphincter. There is two muscular layers, external and internal. Which is outermost, it is external, and which is internal, it is internal sphincter muscle. The internal sphincter is composed of smooth muscle, and we all know that smooth muscle is always involuntary muscles. It is controlled involuntarily by somatic nervous system, autonomic nervous system, sorry. And the external sphincter is composed of striated muscle, it is voluntary muscle, and it is 15% of the resting anal tone, it helps in the 15% of the resting anal tone. And the anal canal is 2.5 to 4 centimeter long and begins superior where the rectal ampulla is narrowed by the anorectal ring. That means, from here it is upper part, it is rectum, then it is the anal canal. It is the superior anal canal, it is the inferior. 2/3 is the, here is the dentate line, it is superior part and inferior part. Here is the diagrammatic anatomy and relation to the MRI images. This is internal, this is external sphincter, anal canal, gluteus muscle, intervertebral fossa. Here it is also marking in the MRI images. This male anal canal and this female. Next, type of fistula, mainly in perianal fistula. Types of fistula means, here I mentioned the perianal fistula types. There is mainly 4 types of perianal fistula: intersphincteric fistula, transsphincteric fistula, suprasphincteric fistula, and extrasphincteric fistula. That means, where A, this is intersphincteric. That means this sphincter muscle and this sphincter muscle, they are passes through this, between these two sphincter muscles and open in the anal canal. This is intersphincteric. B is transsphincteric. It is origin from the skin, then it tears the external and internal, then open into the anal canal. This is transsphincteric. That means it's trans. Then the C is suprasphincteric. That means its origins from the skin and upper portion, it is superiorly upwards travel and cross the levator anal muscle. Then it is again inferiorly pass downwards. Then it's open into the anal canal. And last one is the origin from the skin, and it is open in the only one type of fistula, that is extrasphincteric. It is open in the rectum, not in anal canal. Other three are opening in the anal canal. The B, that means extrasphincteric, open in the rectum. The intersphincteric and transsphincteric are the most common fistula. Cause of the perianal fistula. We all know that mainly the infection is the main cause for the anal fistula. So perianal fistula may be caused by several inflammatory conditions and events, including Crohn's disease, pelvic infection, tuberculosis, diverticulitis, trauma during childbirth, pelvic malignancy, and radiation therapy. However, most are idiopathic and are generally thought to represent the chronic phase of intramuscular anal gland sepsis. That means there is so many glands in anal region, there continuous secretion in there. If it is infection happen, then this secretion may be create a path, and then this secretion from the tract. Perhaps the most widespread theory about the cause of perianal fistula is the cryptoglandular hypothesis. That means those I just show you the anatomy, then it will be easy for you. Here is the dentate of Morgani. Here is the cryptal region, and most of the gland situated here. From here there is a continuous secretion. If any infection is there, then this secretion can make tract and it will can create fistula. Now, the role of imaging techniques in evolution of perianal fistula. When we started our courses and when in the early stage of our service, we was habituated with the conventional fistulogram. But now, which department has MRI facilities, maybe they now doctors are prescribed more MRI fistula than the conventional fistula, because it is a invasive process. Conventional fistula is a invasive and MRI fistula is a non-invasive process. And in MRI fistula, without any contrast, we can detect the other infection area like abscess or other secondary fistula or sinus tract. We can easily detect it. So nowadays, MRI fistula is a modern trend. But otherwise, we can do computed CT scan fistulogram with contrast media, anal endosonography. It was till it is used, but it is a invasive procedure. Some high resolution transducer is required for that. Then it passes through the rectum, and it is a painful process for the patient. But in other way, MRI is there is no pain, no other thing. So MRI is the modern choice of the detecting in perianal fistula. The importance of MR imaging in this context lies in its ability to demonstrate hidden areas of sepsis, was already mentioned, and secondary extension, both of which contribute the high rate of recurrence after surgery. If any surgery have done in the pelvic area, that can be easily demonstrated. MR imaging can be used to define the anatomic relationship of the fistula to predict the likelihood or post-operative fecal incontinence. Role of MR imaging technique. The advantage of MR imaging include multiplanar imaging and high degree of soft tissue. We can detect three-planar imaging in MRI easily by 3D imaging technique. MR imaging examination performed with body or face direct coils require no special patient preparation. It is also an advantage. Use of endoanal coils was initially proposed for MR in MR imaging to evaluation perianal fistula, but till it is not used because it has small FOV. We can get small FOV, so we can miss the abscess or any other complex tract. We can miss it. So, but it has good resolution than the normal fistulogram. But till we use widely use the normal MRI fistulogram. Before doing what is the role of the technologist when he or she will do MR fistulogram, the first role of to him or her that they should correctly mention the positioning of the fistula, in which position it is located in the anal region. It will help the radiologist to report it accurately, because when patient will go for the surgery, they need the external opening and internal opening. So there is a methodology, clock sign. If you imagine the rectum is a wall clock like that, then it is 12 position, which is the anterior portion, and lower portion is 6 o'clock, it is 3 o'clock, it is 9 o'clock. That means if for to detect that, requirement is that you have to position the patient in the MRI table in lithotomy position. In lithotomy position, you have to position the patient in MRI table in lithotomy position. Otherwise, you will diagnose the clock wrongly. That means if you in a lithotomy position, if you find one external opening here, that means it is which clock? 2 o'clock. Here it is 3 o'clock. If it is 6 o'clock, that is, it is also mentioned in here. And those still doing the conventional fistulogram, they for marking they use the metal ring like that in the tip of the series that help to measure the tract length. But in MRI we cannot use the metallic any implant or metal. So instead of that, in my institute we use vitamin E capsule. Vitamin E capsule consists of water soluble fat, so it is easily detected in T1 weighted images. So we before doing the MRI just take a vitamin E capsule and wrap it with micropore. Otherwise, if you openly stick in the area, it can be in heat, it can be ruptured, and it will be again like the spillage and other abscess like that. So it is better wrap in a micropore, then fixed it in the area. It will easily help you to detect the later when you go for the planning, it will help. In the next step is the very important step. In normally we when we take the transverse and coronal images, we take slice like that, in that way, parallel or perpendicular to the body axis. But in case of fistulogram, you should take the slice parallel or perpendicular in respect to the rectum, not for the body. It is too much important. So first take a sagittal image, then plan it oblique coronal and oblique axial. The imaging sequences are reference image T1 weighted coronal or trough for detecting the vitamin E capsule. If you take T2 weighted image, fat will not be bright. In T1 weighted image, fat will be bright. If you take steer image, it will be suppressed. So better to detect the opening, to detect the capsule, you should take T1 weighted image, then you go for T2 sag image, then the main sequences T2 steer, or we in my institute we take M Dixon. It is a fat saturated technique, but it is another method in respect of steer. And the core oblique and additional 3D cell sequences from which you can post processing method you can create tra or coronal or any oblique slices. Additionally, if contrast is required, T1 fat surface image, post contrast, and sometimes diffusion weighted image. Steer sequence provide good suppression of fat signal, but the image tends to be poorer spatial resolution. Then frequency selective fat saturated T2 weighted. Frequency selective fat saturated T2 weighted, that means M Dixon image. It is frequency selective, that means only the fat tissue will be suppressed. In steer, fat tissue also suppressed, but those are the short T1, they may be suppressed. So steer, if you don't in your institute don't have that M Dixon, you can go for the steer. It's no issue. Till now, I told about the perianal fistula, but sometimes you will also get the prescription, which same in the in prescription fistulogram, MRI fistulogram, maybe mentioned in the anal, but it is missed. It is not in the anal. This type of fistula is pyloneedle fistula. It is just above the buttock where cleft. This is the pyloneedle fistula, it is called. For that fistula, you should not plan like that normal perianal fistula. Then you have to plan in this plane, normal axial, normal chord, or as per the sinus tract. And here you have also take the gradient echo sequence to detect the any relations of fistula with the bone that have bony erosion like that. Here is the some example of the fistula. It is a intersphincteric fistula. That means that this fistula tract is in between the two sphincter muscle, extrasphincteric and intersphincteric. This is the intersphincteric fistula. This one. It is opening in which clock? 6 o'clock. It is internal opening in 6 o'clock, external opening in 5 o'clock. This is transsphincteric fistula. That means from opening here it is travels through the external and internal, and then it's open into the rectum. It is a transsphincteric and it is also a complex fistula. Same patient, it is a transsphincteric complex fistula. That means here it is opened in 6 o'clock, but then there is a blind tract in upwards. Earlier I mentioned the use of the vitamin E capsule. Why is it useful? Here this patient has no discharge. He came in department with the history of fistula, but first we place the E capsule. Here it is. So as per initially we didn't find any tract. Then detect this capsule, we can find that there is a small sinus tract here. On the left side there is a small sinus tract. So it is too much useful to place the vitamin E capsule as a marker. This case is the post radiotherapy patient CA rectum. Here sagittal image is very important in this patient, in this case, because there is a tract from the rectum to the urethra. Here it is, and another tract is from the just inferior to the coccyx. So other tra and cord is not too much important. These sagittal images are very much important in this patient. So you have to very much concentrate on which plane do you require more. And this is the pilonidal fistula, case of pilonidal fistula. Here is the fistula, and it is the T2 state image, and it is the gradient image where you can easily that it has no relation with the bony coccyx. Here is the fistula, and this is also the here is the fistula tract, and here is the bone part, that there is no relation. Thank you very much. Any questions?